Good afternoon and welcome. Thank you. We are doing it's the fourth episode in our series talking about everything endometriosis as part of Endometriosis Awareness Month. So today we have Dr. Femi Olarogun from Hart Fertility, and we've had quite a few talks with you, Dr. Olarogun. Thank you and welcome.
Thank you very much. It's good to be here again.
Pleasure, thanks. So we're going to talk about today's topic is entitled Diagnosis and Screening of Endometriosis. And our first question is, what are the challenges associated with diagnosing endometriosis, particularly in the early stages?
That's a good question. I mean, so the general feeling is that around the world, diagnosis is always a problem for doctors because they don't think about it. Even though you thought about it when you're in school, you find that people don't, GPs and sometimes even gynaes don't think about endometriosis as a diagnosis when that hits them in the face. So in other words, when they've been told by a patient that they have very difficult periods that keeps them away from school and keeps them away from normal activity, and that's been going on for a while, very heavy periods, it often doesn't click. And the reality is that a lot of those patients would have endometriosis. Diagnosis is difficult because, nowadays you can make a diagnosis based on history alone. So that's a recommendation from the endometriosis societies around the world that you should not necessarily wait to do a laparoscopy to make a diagnosis. The gold standard to make a diagnosis has always been laparoscopy. So you need to do that to make the diagnosis. That's what it's always been, but that's not the case anymore. It's been felt that you can empirically make a diagnosis of endometriosis while after you've taken the history and you examine the patient. So based on history, part of the history I've alluded to already, and examination, you can already start thinking about the diagnosis. Maybe not completely confirm it, but everything taken into consideration: family history, history of the patient on cycles or chronic pelvic pain, sometimes bladder pain. There's a lot of things that comes into it. You can already make the diagnosis in your mind that that's what is doing. And you can actually start treating even before you get to a laparoscopy. So the problem has always been that people tend to miss or not put, they treat those things as things that are very common. They say, your sister had it, your mother had that kind of pain. It's okay when you have a child. So that's always the story. But the diagnosis can be simplified if you don't think about the fact that you need to do a laparoscopy to make it. You can just make it based on the history and examination alone.
Okay, perfect. Thank you, doctor. Our next question is, can you describe the diagnostic tools and techniques used to identify endometriosis?
Sure. I already alluded to some of it. Part of the diagnostic tool is the fact that you take a good history and you examine the patient.
Yes.
One of the things you should do when you examine the patient is really do a rectal examination, because there are certain things you feel when you do a rectal examination, like a nodule or tenderness in the pelvis, that alludes you to the fact that you might have endometriosis. So based on history, physical exam, yes. And then laparoscopy, like I mentioned, is the one way that you could probably be sure that that's what you're dealing with. You can have a direct look under magnification, laparoscopy, and then you can actually see those nodules and be able to make the diagnosis. Sometimes the diagnosis is actually missed at laparoscopy as well. So it just depends on who is doing the laparoscopy, especially in those young patients you mentioned earlier. The disease might not be very established yet. So there are some subtle changes that you find in the pelvis that you would miss if you were not thinking about or not experienced in picking up endometriosis at laparoscopy. So that's next thing. But before laparoscopy, which is quite invasive, you can do other things like an ultrasound scan, which if you've got an endometrioma or endometriosis on the ovary, you can pick it up. And with good skilled ultrasonographers, you can actually pick up other signs of ultrasound, especially vaginal scan, that tells that this patient might have severe endometriosis as well, like slidings, they call that a sliding sign, and a few other things that you can actually pick up on ultrasound scan. But the one that we normally use that is not as invasive is the MRI. And the problem with that is often the medical aid has issues with paying for it.
Yes.
But the MRI is a lot more incisive in actually looking for endometriosis. and being able to make a call on whether the patient has endometriosis or not. So good history, good examination, proper examination of the patient, MRI and ultrasound, depending on how skilled you are with the ultrasound, and MRI is definitely up there. And then laparoscopy is the final pathway to actually get sure.
Okay, perfect. Thank you. Our third question is, how important is it to seek help from a specialist, taking your fertility into account when managing endometriosis?
Very, very important. As we know, endometriosis is one of the main causes of infertility, around the world. And part of the problem is what we alluded to earlier, that the diagnosis is often delayed. If you make the diagnosis early, theoretically, you could control and manage the disease with surgery or with medical things that would then prevent the disease from being completely, you'd say, for instance, you pick it up early, then you do it before it becomes the stage 3 or stage 4 endometriosis, which would definitely affect fertility and before the patient definitely needs IVF. So if it's diagnosed early and the treatment is instituted early, whether with surgery or with medical therapy, you tend to perhaps prevent onset of progressive disease. So you don't have a disease that is now on stage 3 or stage 4, and you pick it up relatively early. So that theoretically might be a way to prevent the patient from having very severe infertility going forward. And also the quality of life. Remember, these patients live with so much endo, and they have pain, and the pain becomes chronic. So that's all the thing about it. It takes over their life completely. And they just live with pain day to day, and they're using painkillers every single day. Again, if the diagnosis is made early and treatment is instituted early, you can manage it better. So it's essential that once you start having those symptoms and signs that I mentioned at the beginning, that you seek help from somebody who can diagnose the disease and get on the disease nice and early, so that those things don't then later.
Okay, thank you. Are there any emerging technologies or advancements in diagnostics that will promise in detecting endometriosis more accurately? That show promise.
Not really, to be honest, because those things that I mentioned earlier regarding making the diagnosis are still what we use all over the world to make the diagnosis of endometriosis. There's been exploration of blood tests, but none of that has been proven to be absolutely sure to say that, okay, you do a blood test and then based on the results, we can see you have endometriosis or not. There's a few of them in the pipeline. In other words, it's been experimented with and been analyzed and studied, but we're not quite there yet. Yes. It would be nice to have one of those where you can just do a blood test on the patient and tell you, okay, fine, that patient has endometriosis or she doesn't have endometriosis.
Yeah.
But unfortunately, we are not quite there yet. So those things that I mentioned are still the way to go: proper examination, physical examination and history, and then MRI, and subsequently laparoscopy to try to make a diagnosis.
Okay, thank you. Our last question is, what should women do if they suspect they have endometriosis but have not yet received a diagnosis? Oh, okay, I think are you there, Dr. Olarogun? There we are. You're back.
Sure. Yes, I'm here. So I lost you. Yeah.
Sorry.
So you didn't finish that question. Yeah.
Yes. So what should women do if they suspect they have endometriosis but have not yet received a diagnosis?
They must seek help. So, I mean, my feeling is probably see a gynecologist, a general gynecologist. Those are easier to see than fertility specialists or endometriosis specialists, for instance. But start with the gynecologist and explain to the gynecologist that based on your history, you suspect that you do have endometriosis.
Yeah.
And they, try and explore this further, because as opposed to don't mention it, they might then not go there. So perhaps try and see a guy, even if it's a GP, but you've got to mention, I would think that they need to mention to the GP that it's likely, I think I've got endometriosis. And I see patients that come in and say that. Not to that you make the diagnosis. Doctors don't like to hear that patients have made the diagnosis for them. But they can suspect that I have endometriosis based on A, B, C, and D. And then let's take it up from there. You don't necessarily have to go straight to a laparoscopy. You can then start with, okay, let's do an ultrasound scan. Perhaps let's if your pains are not settling after we put you on the pill for 6 months, maybe. So you got to put a time limit. Put you on the pill for 6 months or put you on the exam for 6 months. If it doesn't get better, then we're going to do a laparoscopy or refer you to an endometriosis specialist. But at least you've begun the journey. So if that's suspected, you can see someone, have a discussion around it, and then, take it up from there. And there are other groups as well that you know of, that, endometriosis support groups that are available in South Africa and some internationally. Perhaps, throw it up from there and see what people say, who they want to refer to, in terms of, distance that you can see to help with the disease.
Perfect. Thank you, doctor. I just got a last question for you. Is endometriosis something that you are able to assist patients around South Africa with? I think more in Cape Town and Namibia. This is something new.
Yeah, that's what I do. I mean, most reproductive medicine specialists are, quite adept with dealing with endometriosis. It's one of the areas that I've worked in for so many years. So I do a lot of endometriosis surgery. And I'm always, happy to help patients, with endo. In Namibia, however, I do not operate there, which is a clinic. So all the procedures that I do for endometriosis will be in Cape Town. But yes, I'll be happy to help. Yeah.
Awesome. Thank you very much, doctor. Thank you for spending the time and doing this talk with us. If anyone wants to get hold of you, how can they get hold of you?
It's quite easy. I mean, I work in a number of places. Hart Fertility Clinic, as you mentioned before.
Yes.
We have a website, and we also have an email that you can email. But you can directly email me as well, which is rogunes@gmail.com. I can respond from there. The numbers for the other clinics are also on the website. So at UCT Private and also at University Medical Center, and those numbers are available on the website.
Awesome. Thank you very much, doctor. So Dr. Olarogun is based at Hart Fertility, and you are welcome to actually find them on Instagram. They're on Facebook, and you can go to the website as well. So thank you again, Dr. Olarogun, and we chat to you again soon. Have a lovely evening. Have a lovely day further. Thanks, doctor.
Take care. All right. Cheers.
Bye. Bye.